The sensory examination is, I think in most people's minds, the most difficult part of the examination to actually understand. It takes a lot of experience because it is inherently and by definition subjective. There's virtually no way to get around the fact that you need the person's cooperation to help you with the sensory examination. They're going to have to say to you, I do or do not feel this. The history, of course, is going to be extremely important. When we do a complete or detailed sensory exam, it's almost always because the patient has made a complaint to us, which indicates that there could be a sensory problem. Now, not all of these complaints will be directly sensory complaints. That is to say, not everybody will say, I am numb in my feet, or I am having burning in my feet. But they might say to you, I'm having trouble walking. And because we know that sensory function is so important for walking, it'll go through our minds, I wonder if there is a sensory problem which could be accounting for this gait disorder. Some people, of course, will complain of a sensory problem. My feet burn at night. When I lie down in bed at night, my feet are bothering me. Or I have a numb place on my face, one side or the other. When you take the history from such a patient, what's really critical for you is to think to yourself, what is the distribution and the pace of the illness? This is the trick which will allow you to know how to start in what otherwise would be an infinite neurological examination. It could take you hours and hours and hours. So the features that I'm really interested in is the distribution of this problem. Is it symmetrical or asymmetrical? Symmetrical illnesses are more likely to be metabolic in type, be a systemic illness of some sort, than an asymmetrical illness. Asymmetrical illnesses are more likely to have some structural cause, like the entrapment of a nerve. Carpal tunnel syndrome would be a good example of that. And secondly, where did the illness begin? Did it begin in the feet, the hands, the face? What I'm getting at here is a very important principle of neurology known as the length rule, or some people call it the dying back rule. It's intuitively obvious. Nonetheless, it's worth reiterating. It's so valuable. If you have a neuron and its cell processes, dendrites and axons, axons carrying information away from the cell body, dendrites carrying information toward the cell body, if you make a metabolic disease of that neuron, no matter where that neuron is, whether it be in the central nervous system or the peripheral nervous system, it will be more metabolically sensitive, more likely to become symptomatic the longer it is, the bigger the cell is. It's just a bigger metabolic job. It's as simple as that. So if you have a big, long dendrite or axon, it's likely to fail before a slightly shorter one fails, and before a slightly shorter one fails. This is known as the length rule. So if I take a metabolic disease, let's take a typical example, diabetes. It affects neurons. Let's say sensory neurons in the dorsal root ganglia. You would expect that the longest dendrites would fail first, and that's where the symptom would appear. So to be specific, what would a person actually say to you who was beginning to experience a diabetic sensory neuropathy? They would say, my feet burn, because those are the longest dendrites. And as the disease progressed, perhaps over years, certainly not rapidly, but over years, shorter and shorter dendrites would be affected. And by the time it reached the knees, it would start to affect the fingertips, because after all, the dendrites coming from the fingertips are about the same length as the ones coming from the knees. You shouldn't see the fingertips affected until the knees are affected. And when it gets about to the elbows, this would be pretty bad, right? We're now affecting dendrites only this long. You'd start to feel it on the chest, anteriorly on the chest, because that's where the ends of those dendrites live. And as it got worse and worse and worse on the chest, eventually you'd affect the dendrites only that long. And then you'd feel it on the face, wouldn't you? In the distribution of the trigeminal nerve. And to be precise, you'd feel it right in the top of the head and right at the tip of the nose, right? The longest dendrites, and then ultimately more and more and more severe. Now, you say, well, that would never happen. I mean, who's going to live that long to have that kind of a diabetic neuropathy? That's true. You probably wouldn't see it in diabetic neuropathy, but there are other neuropathies, metabolic in type, which would progress in that way. Porphyria would be an example. Rare, but an example of that. Anything that does not follow the length rule either is not an axonal or dendritic disease, it's not a neuronal disease, or alternatively, it's a central nervous system disease, not peripheral at all. So whenever you hear a story of something that does not follow the length rule, you should say to yourself, this can't be axonal and dendritic. This must be either demyelinating or it's central. And that's the kind of thing you're going to try to sort out when you examine the patient. Finally, you need to know the pace of the illness. How fast is this getting worse? Did it start yesterday and it's getting worse to the point where the hands are numb today? That would be a viciously fast axonal or dendritic disease. Or has it come on over years and years and years like a diabetic neuropathy would? If it's highly asymmetrical, one hand and not the other hand, very unlikely that it's a metabolic disease. After all, how would diabetes be able to separate the neurons belonging to the right hand to the ones belonging to the left hand? Now, it couldn't happen, could it? It must be a local thing of some kind, and that's where you begin to think about entrapment kinds of neuropathies. So with that little bit of background, how are we going to actually do the sensory examination? We've taken a history. We have a hypothesis in our mind about this. This is demyelinating, not demyelinating, symmetrical, asymmetrical, acute, subacute, or chronic. Now we're going to examine the person. Well, we divide the sensory exam into two components, into what are called the primary modalities. Those are the building blocks of sensation. That's pain and thermal sensation. We'll call that nociception, meaning noxious information, noxious meaning potentially tissue damaging stimuli, like extreme hot, extreme cold, pinprick. Those are carried in naked nerve endings, in C fibers, very thin, poorly myelinated or unmyelinated fibers back to the central nervous system. Then there's non-noxious information, such as vibration sense and position sense and touch. These are carried in big diameter, myelinated dendrites, carrying information back toward the central nervous system. I divide all this information into noxious and non-noxious, slow conducting and fast conducting. Those are the primary modalities of sensation. Pain and temperature, vibration sense, position sense, touch. Those are the building blocks of sensation. And the second component of the sensory exam is what we would call the cortical modalities, or the secondary modalities, by which we mean the brain taking the component parts of sensation and turning it into something meaningful. Can you tell what is put in your hand without looking? Can you tell if I write a number in your hand? Can you feel it or not? That's obviously not the nerve doing that job. That's the cortex doing that job. So let's start with the primary modalities. In the old days, this is a sort of a historic point, we had this very useful but now unfortunately unusable instrument called the Wartenberg wheel. It looks like a medieval torture device of some kind, but actually it was a very useful device. It has pins on it, and you could come up the leg or up the arm, and you could say, when do you start to feel that? And you could easily demonstrate the length rule. Right? You could find that by the time you got to the knee, the fingertips started to become affected, right? So you'd say, aha, this is a length rule problem, it's perfectly symmetrical, it must be a metabolic disease like diabetes or alcohol. Round up the usual suspects. You could do it quickly. Furthermore, you could do something with this that was very useful, which is that if you thought that the trouble was a spinal cord disease, you could look for a sensory level on the trunk. You notice I said before, no matter how bad a neuropathy gets, it'll never produce a level on the trunk below which things are abnormal and above which things are normal. Because when it gets bad enough to affect the trunk, it'll start anteriorly and open up like the shape of a Christmas tree on the trunk. It will not go up. If you see a sensory level on the trunk, below which things are abnormal, above which things are normal, that's a spinal cord disease, myelopathy, one of the most important neurological disorders that you can recognize, because it can be a very important emergency, right? For example, a metastasis compressing the spinal cord would produce this, and it might be life-threatening or limb-threatening for you to diagnose this quickly. So we always look for a sensory level on the trunk, and this would have been good for that, but we can't use it. In fact, it reminds me to use my Purell before I touch a patient. You know, we have HIV, we have hepatitis C now. We don't use the Wartenberg wheel anymore because obviously it could transmit things from one patient to another. What we do have are these disposable little pins. These things actually aren't that sharp, and they're not as good as the Wartenberg wheel, but they're safe. So they're For individual patients, you take it off and there's a tiny little pin. And I'll just touch you lightly with this and you'll feel what it feels like. So you can feel that's sharp, right? Mm-hmm. So if you close your eyes and tell me whether I touch you with the dull end or the sharp end. Close your eyes. Was it the sharp or dull end?
Sharp.
And how about now?
Dull. 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 Sharp. Sharp. Dull.
So you see, he can tell the difference between sharp and dull very accurately. But it's not that sharp a device, and you can make a mistake. So if you go to a place where there's a lot of callus, and you touch with the sharp end, you don't touch sharply enough, the person will say dull. Not perfect. Better is to use thermal sensation, which uses the same exact system, small diameter, unmyelinated systems, exactly the same system, but it can't hurt the person. A cold sensation can't hurt them. You can't stick a hole in them and it's just the same. So does it feel cold?
Mm-hmm.
You can feel it nice and clearly. So close your eyes and tell me whether I touch you with something cold or something that's not cold. Cold or not cold?
Cold. Cold. Cold.
Difference?
Not cold. Not cold. Cold. Cold.
It's interesting. My hands are cold because of this room, and I'm having difficulty. He's having trouble telling the coldness of my hand, which is actually very cold, from the coldness of this device, which has actually been sitting out so long that it's not that cold. Let's try this one more time. Here's a cold sensation, and here's a, let's hope, a non-cold sensation. Let's try it again. Close your eyes.
Non-cold. Cold.
No question about it in your mind that time?
It's
a little tight.
It's a little tough.
Yeah, so you see it's a little bit tricky. I don't use hot, although hot would work just as well, because I can't judge how hot the stimulus is. And I'm afraid that I'm going to burn people, so I don't use hot. I use cold. You can see the trick here. It takes a lot of cooperation, and you can see where the sources of air could come. In any case, that's hot and cold. Now let's do vibration sense. Vibration sense is one of the most important things we do. For this purpose, we use a 128 cycle per second tuning fork. This is a direct muscle spindle stimulus. That's the intramuscular proprioceptor. Feel the buzzing? Good. Let's do it in your hand. Close your eyes. Feel the buzzing?
Yes.
Tell me when it stops buzzing. Let's see how long he can feel that. From my own experience, he's already way down there and normal, and I put it against myself as a comparison. And one loses perhaps 10% vibration sense every decade after the age of 60. I'm 64. My vibration sense in the hand is about equal to his, even though he's 30 years younger than I am. Let's try the ankle. You have your foot. Feel it there. Tell me when it stops.
Stopped.
I'll test it against myself. And I'm happy to say that he and I are equal there too. So our intramuscular proprioceptors are working pretty well. Another test that's often used by people is position sense. I'm going to move your finger up or down without looking. Tell me whether it goes up or down. Close your eyes. Which way?
Down.
Which way?
Down.
Notice I'm making very tiny movements. I often close my eyes and try to make the smallest movement that I myself can feel.
Up.
He immediately feels it. It's very, very accurate. You should hold your fingers on each side of the joint so as to not give the person a clue as to whether it's up or down by the amount of relative pressure above and below the nail on each side. You can do the same thing in the toe. There's no point in my doing that here. Now, another way of testing this same system in the axial structures in the limbs, particularly the legs, is the Romberg test. So let me have you stand up and face that way. And stand at attention, put your feet together just like a soldier. And then look up at the corner. I'm standing behind him. I'm looking at the tendons of his calves. Close your eyes. very stable, really almost no difference between eyes open and eyes closed. Good, sit down. Rombergism, or positive Romberg test, would be a person who would stand at attention, look into the distance, start to sway because he's taking his visual correction off the ground, and then if he closes his eyes, he might even take a step. Now, you don't have to take a step to have a positive Romberg test. The tendons can dance. You can watch the tendons working to try to keep the person upright with their eyes closed. What that is proprioceptive trouble when the person takes away visual correction. I think a lot of people mistake the Romberg test. They think of it as a cerebellar test, but it is not a cerebellar test. It is a test of proprioception. In fact, Romberg was speaking about neurosyphilis, tabes dorsalis, which is a disease that takes away proprioception, and that was the point of his test, was to recognize tabes dorsalis. He was talking about a proprioceptive disorder. The proprioceptive disorder doesn't have to be in the central nervous system. It doesn't have to be tabes dorsalis. It could be a peripheral neuropathy. It could be cervical spondylosis. It could be vitamin B12 deficiency. It's a very sensitive but not specific test for proprioceptive trouble, provided it's in the axial structures. It's not going to pick up trouble in your hands, but if the trouble is in your legs and your hips, proprioceptive trouble, you'll have Rombergism. And the symptom that goes with that is people will tell you that they're unstable in the dark or in the shower. I call it the shower sign. People get in the shower, they soap up their hair, they close their eyes, and they become off balance. They'll often say, "I'm dizzy in the shower." That sounds like Rombergism. Positive Romberg test. You do this test, you say, yes, it is. It's a proprioceptive difficulty. It's a sensory problem with the information being carried in the muscle spindle afferents that are going toward the central nervous system. So we've tested the primary modalities of sensation: pin, prick, and cold, which is the thermal sensation, joint position sense, vibration sense. Touch itself is not particularly helpful because it's carried in so many subsystems that the abnormality in touch is not very useful, and it's also very insensitive. So usually I don't bother much with touch. If all of those modalities are intact, and yet the person has a symptom which makes me think they have sensory trouble, I then do the so-called cortical modalities. Can the nervous system put together information that comes from the sensory system? So close your eyes and don't look. I'm going to put something in your hand, and I want you to feel it. You can feel it or move it around at your will, anywhere you like, and try to tell me what that is.
I would say that's a quarter.
Good. Now, I'm going to ask you a really hard question, just to see what happens here. On one side of a quarter, there's a face, and the other side, there's the eagle. See if you can tell me which side is the face without looking.
This side is the face.
That's right. And you'll find, correct, you can open your eyes, you got it exactly right. I just wanted to show you how exquisitely sensitive this secondary or cortical sensory modality is. So that meant that all the nerves were carrying the information with high fidelity into his spinal cord, up through the thalamus, all the way to the parietal lobe, where his memories for what this was were all located right in his temporal lobes. He was putting that all together and said, that's a quarter. And furthermore, he could actually tell which side of this had the face on it, the smoother side than the one with the eagle. So normal people can do this remarkably well, and it doesn't much change with aging until people get to be about 80 years old or so. They can still do something that accurate. Another test is this one. Let me have your palm. Close your eyes. I'm going to write numbers in your palm, and you tell me what numbers I write. Here we go. Ready? What number was that? 3. Good. And this one?
4.
That's good. And this one?
9.
That's very good. So that's graphesthesia, writing in the hand, and the other one is beautiful proprioception, stereognosis. So he has the ability to take something in his hand, figure out what it is, good stereognosis, and he has good graphesthesia. If I write in his hand, he can tell me what that sensation is. Those are the cortical modalities of sensation. So let me review what we've talked about in the sensory examination. A lot depends on the history. We're interested in pace, the length rule, and symmetry versus asymmetry. Then we focus down, bear down on the parts of the body where the sensory trouble is. Using the screening test, the Romberg test, for axial difficulties with proprioception, And then looking at the primary modalities, pinprick, light touch, joint position sense, vibration sense, thermal sensation, and if those are okay, we go to the secondary modalities, graphesthesia, stereognosis. In his case, of course, everything came out perfectly.